Extract 1. Questions 1 to 12.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Morning, Sarah. I'm Dr. Neil Strathmore. I'm a cardiologist, and you've been referred here from the Royal Children's Hospital for some further follow-up. So why don't you tell me a bit about yourself and what's been happening to you?
Well, I was born with a congenital heart, and I've had surgery in 1991 to correct that. And I was also, a pacemaker was also put in, and I've been seeing my cardiologist at the Royal Children's Hospital since then, and now I've come here.
So in 1991, how old were you?
I was 6.
And how old are you now?
I'm 23.
And so you obviously don't remember much about that, but what did your parents say was the problem with you when you had the surgery?
Well, they tried to explain what it was, which was transposition of the great vessels, but basically they told me that I was out of breath, and that's why I couldn't keep up with the other kids, so I was going to have an operation to make me better.
Do you have any memory at all of the surgery or of being in the hospital?
Yes. I remember the nurses, and I remember the playroom, and I remember finding it really difficult to walk after the surgery.
And so do you remember the fact that you weren't able to keep up with other children when you were little?
Not so much, but I remember my lips turning blue and my fingernails being blue and basically going blue when I ran out of breath or running too much.
So after you'd had the surgery, did you only ever have one lot of surgery, or did you have to have repeated operations?
It was just the one in 91.
Good. And so after that, how did you get on in terms of your exercise capacity?
I didn't start off doing too much, but then afterwards I had been doing ballet beforehand, so I continued on with that. And then I picked up some more dancing, and as I got fitter and older, I was doing that quite consistently.
So during your teenage years, how fit were you?
Fairly fit. I was doing about 5 hours of dance a week, so...
Gosh, that's quite a lot, really. That would be quite tiring.
It was.
And so have you kept that going since you've left school?
I have, but definitely not as much because I've been busy with uni and things like that.
So how fit are you now?
Probably not as fit as I'd like to be, but I'm still taking classes and walking regularly.
So do you have any symptoms? Do you have any shortness of breath?
No, not really. I try to keep watching other people when I'm in classes and making sure that I'm not more out of breath than they are. But normally when I'm turning around, everyone seems to be as puffed.
So if you walk up a hill or walk up a flight of stairs, do you get short of breath?
A little bit, but not enough to be concerning.
So you think you're about the same fitness of other girls of your age?
I think so.
Okay. Now, what about your health otherwise? Do you have any other health problems?
No.
You've already said your breathing's okay. Do you have any cough or sputum?
No.
Any wheezing or asthma?
Not at all.
Your waterworks, do you have any problems with your urine or bladder?
No.
What about your bowels? They're all okay?
Yep.
And your appetite, and you don't get any nausea or vomiting or anything like that?
No.
And do you get any headaches?
Headaches I get every now and then, but I think that's mainly to do with stress.
Okay. Do you smoke?
No.
Alcohol?
Yes.
How much?
Every now and then.
So on an average week, how much would you drink?
It depends. Probably just once a week.
Mm-hmm. And would that be 3 or 4 drinks or more than that?
Probably no more than that.
Okay. What about recreational drugs?
No.
Not at all? Good. All right. Now, do you ever have any pain in the chest?
No, not at all.
Do you notice palpitations where your heart's beating fast?
No.
And have you ever had any blackouts or dizzy spells?
No, not at all.
Do your ankles ever swell up?
No, not that I've noticed.
Have you had any problems with excessive bleeding or bruising?
I notice I bruise quite easily if I just bump into things, but not enough to be too much of an issue.
Okay. Is there any family history of any heart problems?
No, not at all.
None of your parents or siblings had any congenital heart problems?
Extract 1. Questions 1 to 12.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi Peter, how are you? My name's Rose and I'm looking after your 2 babies today. How are you?
Hi Rose, I'm very well, thanks.
So this must come as a bit of a shock to you, this the birth of your babies 4 weeks early today.
Yes, we weren't prepared for it, I suppose. Sorry.
That's okay. I know it's quite overwhelming, isn't it, when you've come in today and this has all probably been a huge shock and a big surprise. Why don't you come and sit down next to your babies and I'll explain to you what we've done.
Okay.
Because your wife will be down in recovery probably for another hour or so. So let's look at your little girl first. Have you got a name for her yet?
Yeah, this is Olive.
Oh, that's lovely. Is that a family name or?
It is actually. It's my wife's grandmother's name.
Lovely.
Yeah.
So as you know, Olive is a little bit, well, you can see by looking at her, smaller than her brother. And I guess the doctors would have spoken to you prior to the birth about why the babies needed to be delivered this 4 weeks early. And so the concerns I guess we have for Olive are related to the fact that she is small and so she doesn't have a lot of reserve and that places her at risk of some potential problems, which is the reason she's up here in the nursery.
Okay.
The most obvious of those is that she doesn't have a lot of fat to keep herself warm and therefore that's why we have her in an incubator. And that basically creates a nice warm environment to keep her temperature stable because unlike her brother or even a term baby, she doesn't have a lot of what we call brown fat, which she can use to keep herself warm.
Okay. And how long do you think she'll be in the incubator?
Usually most babies will come out when they're around 1,800 grams to 2 kilos, but that will really depend on her. So what we'll be aiming to do is to, once she's stable, start her on some feeds. Initially we'll give her some fluids intravenously. And so once we can start to get some milk feeds into her and fatten her up, and once she's able to maintain her own temperature, she'll come out. So there's no set weight for that to happen. There's no set time for that to happen. It'll be a judgment call about how quickly she starts to maintain her own temperature and how quickly we can bring the incubator temperature down. So Peter, just take me back. I haven't had a chance to look through your wife's obstetric history. These were your first babies, is that right?
Yes, that's right. We found out quite early that we were having twins because we had an early dating scan about 5 weeks, so we've had plenty of time to sort of think about that and prepare. And the pregnancy, we were told that it was a high-risk pregnancy because we're having twins, but everything's seems to have been normal. We've had regular doctor's appointments and scans. And
So your 18-week scan, the babies were both growing normally, is that right?
yes, that's right. And in fact, I think it was at that point, the scans were getting quite stressful, I think.
Yes,
so
of course.
because we thought things were quite normal, I think we missed a couple of scans after that.
Okay.
And so we had the 35-week scan, and everything seemed normal, and my wife felt healthy. But then we had the scan, and I think the sonographer was quite worried.
Right.
And so we went and saw the
Into
doctor
panic mode.
immediately.
Yeah.
Yes, a little bit. And so the Olive's placenta was a little bit sort of smaller and used up. It had less fluid in it, and I think they were just concerned, and so they thought we had to take the babies out immediately.
Yeah. So that would have been obviously quite alarming for you. Did your wife get antenatal steroids?
Yes, she did. So they arranged for us to have a cesarean on Friday to get Olive out, and the next day, Wednesday, we went back in, and Thursday, and my wife was given steroids, and I think the baby's hearts were monitored as well for quite a long time.
So she had 2 doses of steroids.
That's
right, fantastic, And we can see that those have worked beautifully because Olive is not actually requiring any oxygen at all.
Okay.
We've just put a little light shining on Olive's foot there. That's called a pulse oximeter, and that's just measuring her oxygen saturation levels for us. And they're reading 99 at the moment. She's having no problems with her breathing, and neither is her brother. And that would be one of our concerns at 35 weeks, that the lungs are still a little bit immature, and so some babies will struggle to breathe by themselves even at 35 weeks. But your babies are doing beautifully,
well, that's good.
And that's the steroids that has helped.
Yeah.
I would say Olive will be unlikely to need oxygen, given how lovely she looks now.
Well, that's good.
But we will do a blood test to check her oxygen levels. We'll just do a little prick of blood from her heel and send that off. We can do that here on the ward, put it straight in the blood gas machine and check that she's doing okay.
Okay.
Very good. So your bowel sounds are okay. So we see that the gas is flowing through, that there's no blockage there. Okay. So now I'm going to ask you to lift up your leg, okay, and keep it up. So let's bring your leg out of the blanket. It will make it easier for you. Just bring it up in the air like that, and just don't let me push your leg down. You tell me if it hurts. Oh! That does hurt, eh? Okay. All right. So let's bring this down. Okay. And now I'm just going to be pressing a little bit on your kidneys back here. Does that hurt you? No. Okay. And how about on this side? Does that hurt you? And that's good. Very good. Now I'm going to want to have a little bit of an examination to look at your tubes and your ovaries, what we call a gynecological examination.
Exam is normal?
Very good. And another thing that we need to do is do a rectal examination, and that's to put a finger in and feel the area
that
where
examination is normal as well.
It is normal. Okay, very good. So that concludes...
I have a question for you. What's your diagnosis?
Well, my principal diagnosis is appendicitis at this point.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Come in. Are you a nurse?
Mrs. Miller, I am a nurse.
Can you get me some pain medication? That other nurse last night was just awful. I only saw her once at the beginning of the shift, and I'm really, really uncomfortable. And I just don't feel good at all. Is there any way you can give me some relief?
Well, first off, I need to do a complete assessment on you before I give you
How long will
payment.
that take?
20 minutes. Because I'm very busy, and we have other
But
patients.
I'm very uncomfortable. Is there any way? She didn't do anything for me last night.
All right. Well, on a scale of 1 to 10, 10 being the worst pain you ever had, 1 being no pain, or 0 being no pain, where's your pain level?
8 or 9, maybe going more. It's just, I haven't had anything to give me any relief. I haven't had any sleep last night. I kept buzzing the buzzer and she just wouldn't come in. Well, can you do anything for me?
Let me go check your medication orders.
Can you please hurry?
Well, you're not the only patient I have today, so I will do it as fast as I can do it.
I hope so.
All right, I'll be back.
If not, I want to talk to your supervisor.
Okay, well, I don't think that's really necessary.
It may be, I hope not.
Okay, well, I will go check right now for your pain meds. I'll be back.
Thank you.
Question 26. Now read the question.
When Mrs. R arrived on the medical surgical floor, she was an active 67-year-old with peripheral arterial disease, in need of an arterial bypass to restore circulation to her leg. The pain in her left calf has been limiting her activities, especially her favorite pastime, gardening. Unfortunately, the graft became blocked 2 days after surgery. Now Mrs. R requires a below-the-knee amputation. Mrs. R is concerned about returning home after the surgery, as she is widowed and lives alone.
Question 27. Now read the question.
Hi,
Hi.
Susan. I'm
Hi.
Dr. Hakeem. I'm the A&E reg around here.
Hi.
Okay.
Yeah,
Hi,
I've brought George in today because
Okay.
he's just had a really bad fall. I just turned my back for a minute. I was just washing up, and he just, I don't know, he must have got up onto a chair. I've told him
Alright.
time and time again, don't
Okay.
go into the cupboard. But he went into the top cupboard to get
Okay.
some sweets or something, and it just like fell.
Right.
And I don't know what happened, but I think he hit his hand on the work surface or something, and he was crying a lot, and I'm just really
Okay.
worried about him.
All right. Okay. Well, I've had a look at the X-ray,
Yeah.
and there appears to be a broken bone
Oh, God, yeah.
in his wrist. But I've also examined him, and there are a couple of bruises that he has on his body.
Yeah.
So.
Yeah, well, he had a nasty fall. I just did this big
Okay, all right.
crash, and I didn't know what had happened, so I was terrified. But he was just on the floor
Yeah,
crying.
I mean,
and
children.
I was
Yeah,
really scared.
sometimes children can be clumsy like
Yeah.
that.
Oh, he is
But-
such really clumsy. I mean, I've told him time and time again, don't stand on that chair.
Right.
It'll fall over, and it has done. And
It's okay. It's all right.
Question 28. Now read the question.
Hi, it's Mr. and Mrs. Scott.
Yeah. Hi, yeah.
Hi, I'm Chloe McCauley. I'm one of the baby doctors.
Hi, nice to meet you.
Congratulations. I understand you've just had your first baby, is that right?
Yes.
Okay, how are you feeling?
Happy, although these people have been in and out, so we're a bit on edge and a bit confused.
Okay. Well, that's why I've come to talk to you.
Yeah.
Okay.
Tell me what you understand so far. What have people said to you?
Well, basically, after my wife gave birth a few hours ago, they told us the baby was healthy, but they couldn't decide whether it was a girl or a boy. And no one really said anything, and they're just whispering. And
Okay.
We're just confused.
Okay. Well, what you say is absolutely right, and I'm sorry that you feel confused, but sometimes at the beginning things aren't clear and we need a bit of time to sort things out.
Question 29. Now read the question.
Hi. Hey.
Oh my god, I'm tired.
You ready for the report? Yeah, you got room 212?
Yes.
Okay.
Okay. We got a 24-years old female. She came in for abdominal pain.
Okay.
She's been giving Percocet all night. So she's been complaining all night of pain.
Okay.
Let me tell you, she's been busting that call light all night long, so be ready for that.
One of those.
I'm telling you, cranky pants, alright.
Great. Don't have enough
Okay,
going
so
on.
we give her Percocet, she keep complaining of it, of pain. We even give her morphine, but she's still complaining. I'm telling you, I'm so glad that I'm over turning on it to you.
No, I get her. Okay. All right. I'll see what I can do for her.
All right.
All right. Thanks.
Question 30. Now read the question.
You hear a trainee nurse asking a senior colleague about the treatment for a patient with chronic obstructive pulmonary disease, or COPD.
I haven't treated anyone with COPD before. What would we need to do differently?
One of the most important things would be to make sure to prescribe oxygen at levels between 88 to 92%.
Okay, so why would that be necessary? If he's having trouble breathing, shouldn't we prescribe higher oxygen levels? Most patients receive oxygen at levels between 94 and 98%.
Well, in healthy individuals, a rise in carbon dioxide would result in an increased drive to breathe in order to eliminate the excess gas.
Right.
However, in some patients with COPD, this response is blunted, and their main mechanism for respiratory drive is controlled by the level of oxygen in the body instead. If the level of oxygen given to a COPD patient is increased too much, it can actually reduce the stimulus to breathe and cause hypoventilation, resulting in an increase in CO2.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You will hear an interview with a midwife called Christina Morello, who's talking about the time she spent working as a volunteer in South Sudan. You now have 90 seconds to read questions 31 to 36.
Today we're talking to Christina Morello, who's recently returned from South Sudan, where she was working as a volunteer midwife in a field hospital. Christina, could you tell us why you wanted to go and how you felt?
Well, I first arrived at the decision because I was dead set on making a difference to people who had nobody to turn to in desperate times. And, to be honest, from a selfish point of view, I naively thought it would be an adventure. I was just worried that the charities wouldn't need midwives. You always hear about the huge demand for nurses, and my experience lies in delivering babies. My parents, on the other hand, were terrified. They understood the risks better than me and realised that I could be working in very dangerous settings and that I hadn't properly prepared myself. They also warned me about homesickness and being away from my family for so long, something I hadn't really considered until they brought it up.
So, was your role in Sudan very different to the one you'd been doing in the UK before you left?
Very much so. The role entailed a huge variety of tasks, and they were all demanding in different ways. I helped set up maternity departments and trained local midwives in rural health centres. That was incredibly rewarding.
Yeah.
Watching my knowledge and expertise being passed on to other midwives and seeing them help the women in very remote areas who would otherwise have no access to maternity services felt so satisfying, like I was really making a difference. But what really shocked me was the sheer volume of deliveries I was dealing with. It was astonishing. There seemed to be a never-ending stream, and a lot of them were complicated. I regularly worked 36-hour shifts.
Oh, you mentioned that a lot of the deliveries were difficult. Could you expand on that for us?
Yes. Deliveries that I used to see as complicated back home became almost routine for me. I saw breech deliveries, twins, ectopic pregnancies, eclampsia, preeclampsia, and face presentations on a daily basis. And not only that, but all of these extremely dangerous situations have to be dealt with using very little medication. And you're sharing your kit with a team of people who are also working under extreme pressure. There's a desperate lack of funding for clinical equipment, which is why our work is so important. People don't use contraception, and they have huge families. The more children a mother has, the more complicated the delivery. In South Sudan, up to 13 children isn't uncommon, and that often leads to difficult and dangerous births.
Could you tell us about a patient who made a particular impression on you?
I remember when one patient, let's call her Margaret, came to the hospital in labour with twins. When we examined her, it became apparent that she needed an urgent caesarean section. This was impossible, as there was already one being performed, and we simply didn't have the staff or equipment to handle two simultaneously or to do a turnaround in time.
Right.
We had to work quickly together, overcome any language barriers, and really cooperate with each other to make sure that the necessary equipment was sterilised and available as soon as possible. I think Margaret's case really demonstrates how teamwork is everything out there. Eventually, the babies were both born naturally, safe and well. That was one of the happy endings.
It must have been quite a culture shock for you. What was most difficult for you to get used to?
I was in what's called a medium risk placement, which meant that fairly strict rules applied, and that took some getting used to. We weren't allowed to leave the hospital complex after nightfall, which was strange, but not too much of a problem, as I was usually only fit to have dinner and fall into bed anyway. The worst thing was constantly feeling dirty and uncomfortable. There was no break from the heat and humidity, and we only had bucket showers and a limited water supply. Oh, the bugs didn't help matters. They really added to the discomfort, and everybody always had something or other to complain or worry about. A sting, a bite, an itch or a rash.
So what qualities would you say are the most valuable for anyone who is thinking of volunteering?
Obviously, you can't apply unless you have all the qualifications, experience and skills that they're asking for. That's a given.
Right.
Language skills are a huge bonus. If you've even the most basic grasp of the local language, it'll get you out of all sorts of tricky situations. But what you really need is the ability to cope with the unexpected and be up for anything. When you're working in such extreme conditions, your team's the only thing that keeps you going. So if you put up obstacles, you'll cause more problems than you solve.
Now look at Extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on acanthamoeba infection. You have 90 seconds to read questions 37 to 42.
Hello, doctor. What is an acanthamoeba infection, and what are its types?
Acanthamoeba is a genus of opportunistic protozoan amoebic species widely found in the environment. Moreover, it is part of a broader family of free-living amoebae that can autonomously survive in the environment. However, it can also parasitize in humans and result in severe infections. Having discovered as a contaminant of yeast culture in 1930, it has become increasingly appreciated in the past few decades due to its potential to cause diseases in persons wearing contact lenses and immunocompromised persons, and also for its capability to act as a reservoir for various pathogens such as fungi, bacteria, and viruses. 3 major classifications of rare clinical syndromes can be caused by acanthamoeba. A fatal granulomatous amoebic encephalitis that involves the spinal cord and brain, acanthamoeba keratitis that involves the eye and disseminated infection that often manifests in many skin lesions. Granulomatous amoebic encephalitis. Initially, the term granulomatous amoebic encephalitis was coined mainly to define the brain infection caused by acanthamoeba species. Nevertheless, the other free-living amoebae, especially Balamuthia mandrillaris and Sapina diploidea, can result in analogous clinical presentation. Most often, acanthamoeba affects the posterior structures of the brain in patients' diseases such as diabetes, renal failure, various malignancies, systemic lupus erythematosus, and human immunodeficiency virus. Other predisposing factors are organ transplantation, drug abuse, alcoholism, radiotherapy, or chemotherapy. It is often very cumbersome for the early clinical diagnosis of this condition, as symptoms mimic ischemic stroke or some other type of infectious encephalitis. In this condition, the disease usually manifests with headache, confusion, stiff neck, fever, lethargy, and focal neurologic deficits. As the infection becomes severe, the signs of raised intracranial pressure predominate, resulting in coma and mortality. Acanthamoeba keratitis represents a multifactorial process connected with the use of contact lenses. It can also occur in non-contact lens users, especially those with low levels of immunoglobulin A antibodies in their tear film, or changes in the surface of the cornea. The process begins with the disintegration of the epithelial barrier and stromal invasion by acanthamoeba that induces a vigorous inflammatory response and subsequent stromal necrosis, with potential blinding. There is also a chance of bacterial superinfection that further complicates timely diagnosis. Usually, the symptoms are restricted to one eye and include swelling, pain, redness, tearing, light sensitivity or photophobia, abnormal contraction of the eyelid called blepharospasm, and blurred vision when the corneal lesion involves the visual axis. Disseminated infection and skin lesions. If acanthamoeba enters the skin through the nostrils or a wound, the organism can travel through the bloodstream, spread to other organs, and result in a disseminated infection. In such cases, the clinical process can be fulminant with swift progression to death. Infection with acanthamoeba species can also result in various skin lesions that usually start as firm papules nodules, subsequently developing into indurated ulcerations. Yet it is unclear whether such skin manifestations arise as a primary focus of infection or as a result of hematogenous spread from other sites. If they are diagnosed microscopically, The cutaneous lesions are often characterized by focal necrosis surrounded by inflammatory cells, vasculitis, and amoebas themselves. Even then, the condition can be confused with other infection caused by fungi, viruses, or mycobacteria, especially if the organism is not visualized in the single biopsy specimen. This is the end of Part C. You now have 2 minutes to check your answers.